Hello, good afternoon, everyone. So it's a pleasure to see you all here after a long time. I think last we met was in Gurgaon physically. So some of you we are seeing again after some time. Dr. Ramesh, please come forward. So we are going to have a very interesting session, and especially with you people all interested in strabismus, it's going to be more lively. So we have Dr. Ramesh who's joined in. Dr. Ankur and Dr. Murli have very nice presentations, but unfortunately Dr. Ankur has fallen down to COVID. It's still around. So, so he's not been able to come, but he has sent his recorded video. And similarly, Murli has also sent his video. And so we will have Dr. Rohit, I think, join. Yeah, he's there. So great. Good timing, Rohit.
I saw the people go out, I came in.
Okay. So I think we will start anytime soon, or 10:30. 5 minutes to go. Yeah. So it's rare that people give a time before. No? Usually we are running after. So it was an interesting session going on about advertising, which I think we may have to learn. We know nothing about it. There are two things which doctors know nothing. One is finances, and other is advertising themselves. They only know how to serve, and these two things we need to have some instruction course. I think it's good.
Sir, now you are on the other side. I'm sure you will be aware of the finances of everything.
No, that's what I'm saying. That somehow, I mean, we don't know anything about it. So I did a very simple thing. I joined a person who will deal that.
Who is the best? Who is the best in financial dealing?
हाँ वही मैं कह रहा हूँ इसलिए मैं सुन रहा था थोड़ा बहुत जब मैं आया लेट तो so I think Maipal is there, so I don't have to bother about all that.
He's the best in this, so you can be the best in what you do.
Yeah, so I think it's strabismus. I think is something which is very dear to all of us, and sometimes it can be confusing or becoming complex, but we will try to see that it still becomes enjoyable. And as I say, it's Strabis music. Our session is Strabis music. Strabismus IC, if you combine them and you break again, Strabis music. So there is nothing different than that. So it's still enjoyable, especially because we are dealing with children. So I think I will have, as I said, we have very good panelists on our board now, officially I should say. Dr. Ankur Sinha, Dr. Rohit Saxena, Dr. Ramesh and Dr. Murli are there with me. And we are going to deal with complex strabismus simplified. First is an introduction, what's new in strabismus surgery, which I will be presenting. Then Dr. Ankur Sinha will be talking on 6th and 4th nerve palsies. Then we talk on 3rd nerve palsy. Then Dr. Rohit is going to talk about Brown and Mobius syndrome. Then we have the Duane's retraction syndrome cases, which are complicated. Then Dr. Ramesh is going to tell us on one of the very difficult problems, that is congenital fibrosis of extraocular muscles. Dr. Rohit, please you also come on this side.
Okay.
And Dr. Murli will then talk about something which is really complex, blowout fractures and flap tears. Flap tears, I think many of the old timers don't know anything about it. So that's something again very interesting. And then we'll be closing down. So we start with this. What's new and happening in strabismus surgery? First of all, we have moved from cosmetic surgery to something which is that we are going to give binocular vision back. So stereopsis. I generally say strabismus practice is pursuit of stereopsis. That's what my title was when I presented the NAP lecture in Vancouver. It is pursuit of stereopsis. For each one of us, we are pursuing stereopsis. In fact, that is also for each and every ophthalmologist. The goal should be not just 20/20 or 6/3 vision, but to regain the stereopsis and good fusion that God has given us. So we are not strabismologists. We are actually restoring binocular vision and stereopsis. So there are critical periods that we need to remember, and that is the rule of 6. As in cricket, we say 4s and 6s are more important. So for congenital cataract, we all know, but we should be able to detect it by 6 weeks and restore vision. 6 months, we should be catching up any child having infantile esotropia, and that is also for a manifest exotropia, by the way. Then 6 years for intermittent exotropias, we should ensure that they are restored. Any other condition like nystagmus, refractive errors also should be taken care of by 6 years of age. Even in adults, by the way, timing is very important. A very nice study has shown that even in adults, macular binocular vision continues to be susceptible to permanent loss in adult patients. So we need to restore within a year in order to restore binocular vision. So have things changed in management of strabismus? Spot diagnosis and spot management? No. Still it is not going to be there. We need to follow the simple recipe of observe, confirm, infer, plan and execute. So my recipe is always OCIPE. So first of all, the weakening procedures, we have adjustable recessions coming very handy, and whenever we have a tough situation, like I'll show you in one case, we will resort to an adjustable surgery. You may choose to do a 2-stage surgery at 5 to 6 hours or after 24 hours, depending upon your own ability or convenience. So some steps which are important in adjustable surgery, we all remember that we will usually choose to do a limbal incision. We will have the marks made just as same as we would have done conventional, but here the difference is we will pass the spatulated needles radially, not tangentially but radially, and I usually do a hemi hang back, so I will pass them little away from the mark that I have made, so I have a room for advancement, and recession of course one can do. Silk suture is placed between the sclera and a 1.5 knot is passed so that we can easily undo the knot. Just COVID has taught that the masks are of two kinds. The one which has a sliding nose and the other one has a 1.5 knot. So it can be whatever your choice is. Now this interesting case, as you see here, this individual 32 years old male, he has 612-636 vision. He suffered a road traffic accident 5 to 6 years back with intracranial hemorrhage, and he was having a bitemporal hemianopia along with an esotropia of 35 prism diopters. So interestingly, he has no diplopia, but he has an esotropia which is cosmetically troubling him. But he has binocularity, so we can't treat him like any other cosmetic person. If you correct his esotropia a little more, he will start complaining of double vision. And if you leave him, he will not be happy. So in such a situation, we would resort to doing an adjustable surgery. So here I did a lateral rectus plication of 8 millimeters, a medial rectus recession which I left at 6 millimeters, thinking that it may require that, but we had to advance it to 3.5 millimeter, and finally the diplopia got resolved. So this is a good situation in which adjustable surgery is to be done. Similarly, another thing which is there is the plication, which all of you must be now doing more and more instead of resections. Plication is a technique which is much simpler. Now for all the medial rectus resections nowadays I do plications whenever in exotropias I am doing. So you may have seen this video on the YouTube also, but just see what we have to do is similar to what you would have done in a recession or resection. You will hook the muscle, separate the intermuscular septum on either side. Now pass another hook. 60 vicryl sutures are passed at the same point as you would have done for a resection, but here 2 interlocking bites are placed on the same point. So it's important that we have a good imbrication in the muscle, and these are 2 separate sutures now. Now the difference is here that I am passing a bite in the sclera just in front of the insertion, and then a figure of 8, and then going back into the muscle. So this is something which I call it as the reinforced plication, and we have published the results that it is definitely giving us more lasting results. And it's very easy. Then you just easily fold it on an iris repositor and your job is done. There is no cutting of the muscle, so no bleeding and no risk of slipping. So this is definitely a great advantage. There. Another problem that we sometimes deal with is the near distance disparity. Some may have, like in ESOs, we know it may be a convergence excess esotropia, which is a problem. Sometimes it may be a divergence insufficiency. So whenever the difference between the near and distance measurement is more than 15 prisms, we call it significant. 10 or less is fine. We are going to do as it's a basic one. So in convergence excess esotropias, you all know that we prefer to do a Farden added on to that to take care of that additional excess which is coming for ESO. But for lateral rectus, Farden doesn't work well because there is a large arc of contact. So you can't do a functional Farden at all. So what do we do? the Scott procedure, the combined resection and recession on the same lateral rectus, is something which gives us such results. So this is a case in which the near distance disparity was there. So here I think I can skip this. Basically what you need to do is resection and recession on the same lateral rectus. After hooking the muscle, getting the muscle out. Okay, it doesn't move on. So on this, do we need that video? Maybe let's. Okay. इसको हम फॉरवर्ड कर सकते हैं? इसमें यहाँ पे आ जाए? अच्छा आ गया. अब आ गया. So now what you see is that we have marked it, how much resection we would do at that point. In recession we would have passed the sutures just at the site of the insertion, maybe 0.5 millimeter. Here we have calculated how much resection has to be brought in. So that point I have marked, and 60 Weichel sutures I have placed. Now just as you would have done a resection, a light cautery in front, and then this part is resected. Now this is X amount of muscle. This is resected. And now we'll do the recession. So recession, maybe if it is Y, then X is equal to Y would mean like a Farden operation, which is described as an adjustable Farden. The same amount of resection and same amount of recession done. But if you are doing little more recession, that is going to give you the correction for the primary position. So you have two components. One is the correction for the primary position, and the other is the limitation in the action of muscle. So this is what is Scott procedure in simple. Coming to the obliques, I have been talking about again and again that we should avoid doing inferior oblique myectomies and superior oblique free tenotomies. So we have very good procedures, inferior oblique weakening, when the muscle can be still on your hook. And this is, you are all aware, we had pure recessions, inferior iliac and Nankin anterior positioning, which is more standard procedure for DVDs. And then we have the modified iliac Nankin, in which we are going to put the posterior suture closer to the lateral border, 5 millimeters posterior. But the newer addition which is there for the last now almost 2 decades is Stager's anterior nasal transposition. Now there is a small video clip of this. This is a very useful procedure. People say that inferior oblique, if it's a 4+, what will you do? You can do an ANT. Even cases which have come up to me after a surgery of inferior oblique done, and if it was, let's say, a recession, then I am able to do it, I can do more surgery on it. But if it is a myectomy, there is a problem. So that's why I again and again say, please don't do myectomies. You can never go back. Always use an eraser which has a eraser behind a razor. Any razor is good if it has an eraser behind. A surgeon is good if he can erase what he has done. So now see this. We have passed the sutures in the inferior oblique, taken out the lateral rectus hook, hooked the inferior rectus. Now this conjunctiva and over the inferior rectus is being displaced, and you are going to make a small nick in the intramuscular septum nasal to the inferior rectus. Now this inferior oblique is brought on the nasal side. See that how it's coming easily. Just need to do a little dissection around and it will easily come on the nasal side. And now you have a choice how much you want to do. You may do very good amount of weakening if you can bring it more and more nasal and anterior. But if you do a little 2 millimeters posterior to the nasal border of the inferior rectus, you would not get an anti-elevation also. So that's another advantage compared to a iliac and Nankin or a total interpositioning. So this is how the muscle has been resutured, and this takes care of it. This will correct the torsion. Superior oblique surgeries, weakening procedures are several, and we have a good range that we can deal with any amount of superior oblique overactions, and you may have your choice depending on what type of overaction is there. The mild ones are easily done by the posterior tenectomy of superior oblique, in which the anterior fibers are left and we can always go back to the superior oblique. A translational recession is a choice when you have a 3+ overaction of superior oblique. But if there is a Brown syndrome, my choice is usually the loop tenotomy of superior oblique. So this child has a See, you do an exaggerated force reduction test. On the nasal side, it was not moving. So on the superiotemporal incision has been made, hook the superior rectus, pass the long blade retractor, and now the superior oblique is being hooked. You can easily cut it. Now obliques are something which you can cut without passing sutures prior. You just need to hold them with the forceps. And here we are going to use 5-0 ethibond suture, non-absorbable suture, so that we can have a hang back done. So now the FDT is free. The nasal side also, the eye moves up. And now you can do any amount of recession that you want to. It's a hang back recession basically, which is loop tenotomy. And now this is the thing, and now you can easily slide the superior oblique. So you have a control on the superior oblique rather than leaving it free. And if you require to do more, you can revisit, pull the sutures and get it done. Finally, you may have heard of Joseph Deemer's lecture on the sagging eye, the myopic cases, high myopia, heavy eye syndromes. Now these are something which perplex us all, and how to deal with it. So first of all, yes, you will do an FDT to see that medial rectus, if it's tight, it needs to be recessed. But otherwise, what you do, there is a problem that these are having, as you go back in this picture, see these arrows. This is the basic problem. Yokoyama showed us that it's a nasalization of the superior rectus and the inferior rectus coming on the medial rectus side. So there are 3 recti muscles on the nasal compartment, and the lateral rectus is like opponent who has so much problem, it runs away and it comes in the inferior compartment. So even if you tighten the lateral rectus, it will not be of any help. It will only cause more hypotropia. What you need to do is this superior rectus has to be brought back to the temporal side. So this is a procedure that we'll talk about. The bimedial recession along with loop myopexy for heavy eye with high myopia. So this is the superior rectus, 8 millimeters behind. So what I usually do, although the classic Yokoyama procedure is 12 or 13 millimeters behind the insertion, I find even 8 millimeters behind is fine. As we do the Nishida's procedure, it works, and same can be done for this also. So here these, again the ethibond sutures are being used, mind you. So 8 millimeters posterior to the lateral rectus on the sclera, these bites are taken. 2 bites are taken in the sclera, and again muscle sclera muscle, MSM. You took the muscle bites, you take the scleral bites, and again muscle bites. This will give you a good control on the superior rectus so that it shifts to the temporal side. You don't require any other extra armaments, although people have used silicone bands. In myopes, actually, the globe is such a large thing, orbit is small, already there is a space constraint like Bombay. So I would suggest just using sutures will suffice. And then you take the bites in the lateral rectus. So there's a loop myopexy which has been done to the sclera. So you attach both superior rectus and lateral rectus in the superiotemporal compartment of the sclera. You have to be careful because these are thin scleras in myopes. Then mini tenotomies are there, which I have not used, but I have heard Dr. Kenneth tried doing. But something which I have recently tried my hand on is mini plication, and this is also a very good procedure for small amounts of leftover deviations. Like this girl, she was going back to US and she had a 10 prism diopter. She had been operated elsewhere, and this was what was the leftover 10 prism diopters. So I tried a left inferior rectus mini plication. In this, you can see the post-op results are good. The advantage is you can easily undo it. So anything which has an eraser behind a razor will work. What more in strabismus surgery? We have tendon sheath stripping, repair of the IR flap tears, which Murli will talk about, muscle transplantations, resected segment used for lengthening, anterior tenectomy of superior oblique, or Sensky's procedure for nystagmus. But now we have Ankur Sinha, who will be telling us about management of 6th and 4th nerve. As I said, he's unfortunately down with
A
COVID.
very good morning to each and everyone. At the outset, I would like to thank Professor Pradeep Sharma sir and AIOS office bearers for giving me this opportunity. I would have loved to physically attend this DreamCon 2022, but I could not be there because of being recently tested COVID positive. I'll be talking on management of
I
sixth and
think
fourth
there's
nerve palsy. Now, what are the signs and symptoms of sixth nerve palsy? It presents with horizontal diplopia worsening towards the affected size. There could be a phase turn, and the measured esotropia would be concomitant, that is greater in the field of action of the muscle.
I think it's
Now, this is
playing
a
here.
case of acute onset post-traumatic diplopia. So what we
Will
see
it
here
run
is a
again?
very good morning to each and everyone. At the
Duplicating it.
outset, what is required is just observation and follow-up as most of these cases can recover with due course of time. This is another case of 34-year-old male presenting with sudden onset diplopia, with headache on and off, with occasional. A very good morning to each and everyone. At the outset, I would like to thank Professor Pradeep Sharma sir and AIOS office bearers for giving, as most of these cases can recover towards the affected size. There could be a phase. Would have loved to physically attend this DreamCon 2022, but I could not be there because of being recently tested COVID positive. I'll be talking on management of sixth and fourth nerve palsy. Now, what are the signs and symptoms of sixth nerve palsy? It presents with horizontal diplopia worsening towards the affected size. There could be a phase turn, and the measured esotropia would be concomitant, that is greater in the field of action of the muscle. Now, this is a case of acute onset post-traumatic diplopia. So what we see here is a left eye traumatic sixth nerve paresis. And what is required is just observation and follow-up as most of these cases can recover with due course of time. This is another case of 34-year-old male presenting with sudden onset diplopia, with headache on and off, with occasional vomiting. There is no other history of any other neurological illness. And there's bilateral abduction limitation suggesting bilateral sixth nerve paresis. On examination, his vision is absolutely fine. The anti-segment is absolutely normal, but what we see is a large papilledema, and the neuroimaging suggests that there is a large intracranial space occupying lesion. So dilated fundus examination is a must in almost all cases of recently acquired sixth nerve paresis or sixth nerve palsy. Now, management options during the acute phase, you can think of occlusion, prisms, and botulinum toxin. 6 months later, when the misalignment stabilizes, we have to plan for surgical correction. For partial sixth nerve palsy, one can plan MR recessions, LR resections, RNR, and RNR can be combined with contralateral recessions. This is a case of left post-orbitotomy sixth nerve palsy, and the patient undergoes a recession resection procedure, and we can see there is a pretty good alignment post-surgery. For total sixth nerve palsy, we have options of partial VRT with MR weakening procedures or full tendon VRT with MR weakening, or we can also have muscle union along with MR weakening. Now, there are a lot of published procedures like Hammershim advocated partial VRT of temporal halves, O'Connor advocated full tendon VRT with LR cinching, Carlsel and Jampowski advocated adjustable partial VRT, Jensen advocated muscle union procedure, Kushner modified the Jensen's procedure to middle halves. All these union procedures can have problems of strangulation of vessels. To overcome this, Rosenbaum advocated full vertical recti transposition with Botox, and Foster advocated full VRT with lateral fixation augmentation suture or the Foster's suture. The newest in the literature is the Nishida's procedure. Originally, it was described along with a muscle split. Later, the muscle split was avoided. So what we do is the temporal halves of both the superior and the inferior recti are transposed to the lateral rectus. Now, this is the original, this is the modified Nishida's procedure where the muscle union is to take place approximately 8 mm from the insertion and 10 to 12 millimeters radially, midway between the superior lateral and the lateral inferior rectus, and there is no splitting of muscles. Now, we can add adjustable medial rectus recession to make the Nishida's procedure adjustable. This is the case of left post-traumatic sixth nerve palsy. The patient undergoes large MR recession with half-width VRT of superior and the inferior rectus to the LR, along with the Foster's augmentation suture. And we can see there's a good cosmetic alignment. This is another case of right post-traumatic sixth nerve palsy with diplopia and primary gaze. The patient undergoes medial rectus recession, which is adjustable along with the superior rectus transposition procedure. A post-viral sixth nerve palsy involving the left eye, the patient undergoes left eye MR recession with superior rectus transposition. Again, we can see the good alignment in these patients. Botox can be used to manage the acute phases of sixth nerve palsy. This is the case of left eye sixth nerve paresis, where Botox has been used to alleviate the symptoms of diplopia. Now, in acute phases without disc edema, observation can be followed. In children, if there is no neurological sign, they should be examined every 2 weeks till full recovery occurs. If it is persistent for more than 3 months, neurologic evaluation is a must. For young adults between 15 to 40 years of age, look for the risk factors. For patients who are more than 40 years of age, rule out diabetes, hypertension, atherosclerosis, and other systemic conditions. These patients may recover fully, especially with diabetes and vasculopathy. Patients with increasing esotropia, developing neurological signs and symptoms, a detailed evaluation is always a must. Now we move on to fourth nerve palsy. Fourth nerve palsy is one of the common nerve palsies seen. It is usually congenital, post-traumatic, post-viral, ischemic. It presents as a head posture, which is usually a tilt, asthenopia, vertical strabismus, or diplopia. It is never a sign of raised ICT, but may be associated with diabetes and hypertension. This is the NAPS classification with respect to the right eye. So if there is a maximum involvement in the levo elevation, right inferior oblique recession is to be planned. That is because we are trying to tackle the overaction of antagonist. If there is a greater deviation in the field of action of superior oblique, that is maximum involvement of the levo depression, then right superior oblique tuck with right inferior rectus recession can be done, or a modified Haradato can be planned in these patients. So we have to plan according to the type of involvement in the 9 gazes as outlined by the NAPS classification system. Try and suspect bilateral sixth nerve palsy if the patient has a history of concussion or closed head injuries, if there is a V pattern, chin down position, alternate hypertropia or alternate head tilt, and the objective torsion is more than 10 degrees. There can also be sometimes subjective complaint of torsion. Now, what are the management options in case of fourth nerve palsy? For congenital cases, plan for surgery. For acquired, during the acute phase, occlusion can be given to avoid diplopia. Botox is not a good choice. 6 months later, we can plan for a definitive management in terms of surgical management. Park's 3-step test is an important test to find out the underacting cyclovertical muscle. So in this case, we have minimum left over right, that is the L over R on examination. And this L over R aggravates on dextro elevation. And this further aggravates when the patient is tilting the head towards the left. So we can clearly see this L over R aggravates in the left head tilt. So it's a case of left superior oblique palsy. A 17-year-old male presenting with tilting of head towards the right side while working, and it is seen since childhood. So we can see there's a slight L over R, with L over R worsening in dextro version and also on dextro elevation. So this is the Park's 3-step test for this patient. This is slight L over R, it worsens on dextro elevation, and it further worsens on the left head tilt. So it's a case of left inferior oblique palsy where left modified dilated Nankin procedure was done for this patient. And this is the post-operative photograph, which is showing you a very good alignment. And this is the Park's 3-step test or the head tilt test where we can see that L over R is gone on the left head tilt. Now this is the torsion, which is markedly improved. This is the preoperative and this is the postoperative torsion. This is another young boy with left superior oblique palsy where we can see there's a marked L over R and there is a gross underaction of superior oblique and the maximum involvement is seen in almost all dextro versions. The patient undergoes superior oblique tuck and this is after 3 weeks. We can see there's slight development of Brown syndrome and this Brown syndrome gradually improves and the patient gets a relatively good alignment. So in the end, I just want to say that careful assessment and proper choice of procedure is key to success in paralytic strabismus. Thank you for your kind attention.
Thank you, Ankur. I think it's hope to get you back soon. So I think as we have seen in the transposition dinner plate, we may have several options. We have the partial tendon VRT, the full tendon VRT, single muscle superior rectus transposition or IRT, augmentation by resection, augmentation by Foster sutures on these muscles, augmentation by cross section, and then we also have the plus effect by antagonist MR recessions, by MR Botox in the opposite muscle, and then agonist LR plication. So these are the different options which are available, and of course the desert with Nishida with modifications is there. So these you have seen some cases shown by Dr. Ankur very nicely. I think we will move on. The Nishidas, as we all know, is a procedure which is no disinsertion, no splitting, so no risk of ASI. Just like the plication, it's a good procedure which we have to our armamentarium. Direct vectorized force to the sclera by non-absorbable sutures, and there is no lax middleman like in Jensen's. So Jensen is something which I have never liked, because it may work for some time. Gradually, the force you are transmitting is through the lax middleman, that is a lateral rectus, which is itself paralytic. It gives way. So gradually, whatever force is there, it will be lost. These are vessel sparing procedures. So now we talk on the third nerve palsies. In third nerve palsies, which is one of the more complex problems that we have, we may have different challenges in different forms. As you all know, it involves almost all the muscles on the one side except the lateral rectus and the superior oblique. So you may have a full picture, full blown picture with an exotropic eye, which may be 85, 90 prisms, neither elevates nor depresses, and of course there may be the pupillary and the involvement of accommodation. So I think for the PGs particularly, never forget that part, that it may involve. The ischemic neuropathies are there which have to be kept in mind, which may be sparing the pupils, not in all but 70%. And then there may be aberrant regenerations which have to be dealt with separately, and you may have associated neurological deficits in many of these people. Now this individual, old individual, had an ischemic mononeuropathy. Why? Because if you look at his pupils, you will find that they are having the same size. There is no anisocoria. So never forget to look. Whenever you have a third nerve palsy, a person is coming with ptosis, exotropia, neither elevates nor depresses, look into the pupil. If the pupils are no anisocoria and the accommodation may be good, of course in this individual accommodation is lost because of presbyopia. So if this is there, then we have to deal with differently. So in these cases, a complete motor diagnosis is made. Since we are suspecting an ischemic or a vascular lesion, we should rule out hypertension, diabetes mellitus, CAD or CVA. So monitor these things. ESR, CRP also should be seen. Thesis done by Dr. Priyanka, we saw that the 60 cases of ischemic mononeuropathies, 25 of the 60 had diabetes mellitus underlying, hypertension in 15, hypercholesterolemia in 8, hyperlipidemia in 20 others. That means triglycerides were raised. So these may sometimes, if you find after a week that there will be an involvement of pupil or there is a worsening, then don't forget to do an imaging. So you may wait for 3 to 5 days when we are seeing these cases which are pupil sparing, but call the patient back and do imaging if required. Management in third nerve palsies, after you have ruled out the causes and then you are kept on follow up, minimum we wait for 6 to 9 months if there is no other thing to be done. And crutch glasses are used for ptosis. Surgery, how we'll do, we'll talk about. Now this case is an example. He is himself a doctor, and what we saw was an exotropia, and in such a situation when the eye is coming up to the midline, I prefer to do a recession and a plication procedure. So you see here LR recession of 24 millimeters was done. So it's a supramaximal recession because we want that lateral rectus to be easily relaxed, and the MR plication of 8 millimeters was done, and you have these post-op pictures, and he is very happy. He is going back to work. If you have a lateral rectus which is tight but not fully tight, LR is not very tight, and there is no crossing the midline, then you have a choice of doing a split lateral rectus transposed to the medial side. So this is a very good procedure which has come to our hands, and we have used it in third nerve palsies with very successful results. And there are several people, and there are a good amount of people now doing even in India. And you will see that there is a combined multi-center study which was published under Linda Dagi. Now case 3, this is again having a large exotropia, but here the verticals are quite a bit, and the lady wanted the exotropia along with that vertical also to be corrected. So what we can do in such situation is contralateral superior rectus recession. If you do, it also takes care of the ptosis to some extent. The pseudotosis element which is there will be improved, and so the hypotropia gets corrected, the pseudotosis improves. So in such a situation, LR Y split to the medial rectus side along with the contralateral superior rectus recession was done. Now this case is having a tight lateral rectus. So if you have a tight lateral rectus, Y-split LR to the medial transposition is not recommended. In such a situation, you have to do a supramaximal recession or a periosteal anchoring of the lateral rectus. So the lateral rectus is anchored to the periosteum on the lateral side, and then you can tighten the medial rectus if possible, or if the medial rectus is totally not allowing that, then you have to anchor the globe also to the medial side. So you have anchored the lateral rectus on the lateral periosteum and the globe to the medial periosteum. So this is another case in which very tight lateral rectus was there and 90 prisms, and you can see that how this has been done. Earlier we had recommended using the DCR skin approach, but now we usually do the precurricular approach. Aberrant regeneration, if there is, then it has a different ball game. Now this individual has a third nerve palsy, but what you see that the lid gets elevated here on this abduction and also in looking down. So this is a pseudo von Graffe sign. So but the interesting part is the exotropia gets corrected. It's not much. So in such a situation, we may not do any surgery, just counsel the patient, and if he is interested for the ptosis thing, we have to explain to him. Now if you have an exotropia which is substantial along with aberrant regeneration, you may choose to operate on the contralateral horizontal recti. Now here the counseling is very important. You have to explain to the person, and usually you will have to show them that what happens. You can take a picture of the person with the contralateral eye fixed in the other side and see what is happening, and then show them that look, the ptosis will get corrected by your surgery being done on the contralateral eye. And this is what was done in this case. And you see here how the exotropia is corrected in the other eye, which corrects the ptosis in the left eye. So the aberrant regeneration can be handled differently. Now this case 7 shows you another type of third nerve involvement in which the inferior division alone is involved. There is no ptosis, there is no superrectus involvement. So inferior division is involved, inferior rectus is involved, and exotropia, the medial rectus, is also involved. So in such a situation, you have to handle it little differently. So what we did was an FDT was done to see the lateral rectus and superior rectus were free, not very tight. So modified inverse NAP procedure. So what we have done, the modification NAP for the inverse means for the inferior rectus, lateral rectus has been reinserted without any recession, and the medial rectus was resected 6 millimeters and then inserted at the RIR. So we have done a combination of NAPs and a horizontal resection procedure to take both into account. The exotropia gets corrected, and you see here the exotropia is corrected as well as the abduction has improved substantially. Another case shows you another problem, and this is a right residual third nerve palsy with lateral incomitance. Now here earlier surgery was done, a right retractus recession has been done elsewhere 12 millimeters with application of 6 millimeters, but still she has an incomitance. Now you see these deviations, 8 prisms here, 16 in the primary position, 35 prisms in this gaze. Now there is a large, whatever you do, you may not be able to correct both. So what should be done? Scott procedure. Now that is something which you can do on the lateral rectus, and that is what we have done. A Scott procedure on the left lateral rectus, 6 millimeter resection and 12 millimeter of recession on the lateral rectus was done, and now you see the post-op, she's got corrected the abduction, and these are okay. The last case is showing you twice operated elsewhere in Kolkata, and the patient came to me. So what I did was explored it. It's a re surgery. So lateral rectus recessed 25 millimeters, 7 millimeter hangback, and an inferior rectus belly transfer. Now half Nishida, a good name has been given, belly transfer surgery, because we are just shifting the belly of the inferior rectus to the side. So it's a belly transfer surgery to the medial rectus. So this was half Nishida which has been done. So important points to remember in third nerve palsy: you look for the deviations in primary position and other gazes. Fixing eye, find out, because you have to deal with which is the target deviation will be determined by the fixing eye. Look for the incomitance. Look for the realistic goals to be set and counsel the patient. Nothing can be corrected fully in third nerve palsies. Individualize the treatment. FDT for the lateral rectus is done, that will decide the surgery. Supramaximal recessions may have to be done, periosteal fixations may be done, and sometimes we can do a split lateral rectus to the medial rectus side. And option of contralateral muscle surgery is also there. So third nerve palsy is a real gamut of procedure. We have to be a squintellectual to handle it, and we are all squintellectuals here. So this is how a third nerve palsy can be after surgery. And now we move on to another complex problem, and we have Dr. Rohit, who is now heading the RP Center in AIIMS, to deal with the problem of Brown's and Mobius syndrome. Dr. Rohit.
Thank you very much, sir, for the opportunity. It's an absolute pleasure to be here, and it's always nice to see halls of strabismus and neuro-ophthalmology getting increasing number of people attending. So thank you very much, everybody, for being a part of this. Sorry? No. Slide. Right. So thank you, sir, for
So in the meantime, if there is any question from okay, it's ready, I think. But you can jot down your questions. We will deal with them. Got it?
escape करके full screen कर देते हैं.
Yeah.
Sure. So thank you for the opportunity, and I'll be talking about Brown's and followed by a few slides on the Mobius. Brown's is something which is not so uncommon, but can be rather difficult to manage. The key findings would be deficiency in elevation and adduction, some deficiency in the midline, minimal or no deficiency in the abducted position, and a V pattern with divergence in upcase. The key investigation to do is to test for the tightness of the superior oblique, which would be tight, and you may not have a superior oblique overaction. But along with that, rarely you may see a significant downshoot in adduction, a widening of the palpable fissure on adduction, an anomalous head posture because the patient will have the head turn onto the same side so that there can be vertical alignment in the opposite gaze. Again, associated with hypotropia in the primary position. In acquired cases, you may have some amount of trochlear tenderness. You can have it divided as mild, moderate, and severe. Mild often may not get presented early. It is just a restricted elevation in adduction. For the moderate cases, there is, along with the restricted elevation and adduction, a downshoot on adduction. So on adducted position, the eye is hypotropic, but no hypotropia in primary position. And in severe cases, you may even have a hypotropia in the primary position. Jimpolsky also added a Brown's plus in which you could have a superior oblique overaction also, so you would have significant hypotropia in adducted and depression. So here you can see in this patient, there is straight up, there is a limitation of elevation. Here is not so significant, a significant limitation of elevation and adduction. Along with that, what you would be seeing is a kind of Y pattern. So as the eye goes up, if you significantly attempt to elevate it, the eye kind of swings out like a Y pattern. So that's where the discrepancy starts. If there is a superior oblique overaction, you're expecting an A pattern, but the patient looking up, the eye moves out a kind of Y pattern. So that's when you start thinking. In the presence of a superior oblique overaction, you would see a significant amount of torsion in the fundus. So Brown's plus would be diagnosed accordingly. You have a lot of differentials initially, especially if you don't understand the eye movements at that time. You can have a true inferior oblique palsy, extremely rare as an isolated inferior oblique palsy, but not uncommon. The most important finding would be that the force duction test for superior oblique will be negative, and you are going to have an A pattern present. So presence of an A pattern, and of course the FDT would help us. You could have sometimes a primary superior oblique overactions, which may be very severe. So you may have the antagonist into inferior oblique not acting not so well, so slight underaction, but again an FD force duction test helps. The other differentials could be an monocular elevation deficit, blowout fractures with inferior rectus, tight inferior rectus, and the eye is not able to go up. CFUMs, although they are very rare, I mean, it's fairly easy to differentiate them because of the other findings that are there. Congenital Browns, the most commonly what you see, the etiologies can be a short anterior tendon sheath, a normal but an inelastic tendon. Basically, the telescoping mechanism through which the superior oblique acts is not there, or there may be attachments here between the movement of the tendon with the sheath along with that. In acquired cases around the trochlea, you may have trauma, post-surgery, as was shown by Dr. Ankur, where you do a tuck of the superior oblique, you can actually generate or create a Brown syndrome, and of course inflammation. So not uncommon to see patients presenting with unacquired Brown. So this was a case of a patient who presented with an acquired hypotropia, and you can see the severe limitation of elevation and adduction, the hypotropia and adduction, not so significant hypotropia and primary gaze. So this was a patient of an acquired Browns. On imaging, you could see that there was a bulky superior oblique with a cyst, which turned out to be a cysticercosis. The patient improved significantly on medical management. So non-surgical interventions, more often than not, many of them would spontaneously improve. You can ask them to give some elevation exercises if they are recent acquired. Steroids injected locally in the trochlear area or oral, and of course treat the underlying cause if it's because of a systemic inflammatory disease. Indications of surgery would be a severe case of threatening binocularity in amblyopia, which would really be an absolute indication, and you would want to go in for surgery, but which would occur in primary position hypotropia as a patient having significant anomalous head posture or unacceptable downshoots in adduction. The aim would be to correct the hypotropia in primary position and reduce the downshoots and expand the binocular diplopia free field. The possible options would be a posterior tenectomy, as Sir talked about, but really it does not relieve the Browns per se. It just removes the posterior fibers. But if you have a tight superior oblique, you're not going to be able to relieve that. The other options discussed are superior oblique tenotomies or free tenectomies, which unfortunately should not be done because they often will result almost 2/3 patients with an SO palsy kind of a condition, and subsequently, although people have described a simultaneous IO recession also, but that would not really be acceptable. Superior oblique recessions were initially done, but because they kind of, after surgery, they kind of collapse the insertion and you lose the posterior fan-shaped insertion, which is the beauty of the superior oblique tendon. That's why superior oblique recessions were given away. Sir has modified that and he does the loop tenotomy we just saw. So, however, the downside would be to an extent of the collapse. The other option is to perform the surgeries a little away from the insertion. So all the other surgeries, the Z tenotomy or the split tendon lengthening, are a little away from the insertion, and you can lengthen the tendon accordingly. So you can do a split tendon lengthening. Wrights described the silicon band expander, which lengthened the tendon. Invariably, the problems of surgery on the nasal side can be that there can be fibrosis around the band or any other surgery that you do. So it's important you approach temporally. The Knapp's chicken suture or a suture tenopexy is probably one of the most favored now, and I prefer that to any other surgery. It can be done adjustable intraoperatively, and you can do the FTT accordingly. So this was a case of a Wright-Brown syndrome. You can see the hypotropia here, the characteristic face turn, and in this patient, we had done a spacer elongation, a silicon band, and you can see, although there is some limitation of elevation still, but you don't want a superior oblique palsy significantly developing, and that's how your endpoint should be. Slightly tight FDT may remain intraoperatively when you are doing the adjustable. This was another case of Wright-Browns. You can see the severe hypotropia in primary position, And this patient was given amblyopathy therapy but was not improving, so we did surgery and subsequently continued the amblyopathy therapy. In this patient, we did the suture lengthening or the suture tenopexy to improve. And again, you can see there is a limitation of elevation and adduction, but you don't want a superior oblique underaction. You have good primary gaze alignment, and the patient's face turn improved. A quick couple of slides on the Mobius, a very uncommon condition. I personally have not seen more than 5 or 6 of such cases. And the most common things that you will see is a bilateral 6-nerve palsy with a large angle esotropia, which is the most important thing you would want to correct for. And of course, associated other things. The other important thing that you must know in these patients is they have a dry eye kind of a condition, and they would often suffer with epithelial defects and other associated problems. Exposure keratopathy, because they are not able to close their eyes adequately. So you need to always look on their corneas and probably manage the recurrent dry eye or erosions that they are getting. They have significant refractive error problems. They need amblyopia therapy and, of course, correction of associated lid anomalies, including an entropion. So goals would be to align in primary gaze essentially and increase the area of binocular visual field. The challenges, of course, are measurement and difficult anesthesia, aplasia or hypoplasia of the extraocular muscles, which again can create a problem when you are operating them. You need to do a forced duction test for the medial rectus. If it's positive, you need to do an MR recession, often tri-adjustable, although it may be difficult because the muscles are rather fibrotic, with a vertical rectus transposition. If the FDT is free, you can just get away as a first surgery as a VRT, and residuals can be managed with botulinum toxin. So this was just to show you the one case. Preoperatively, we did a left medial rectus recession with adjustable sutures with a superior rectus transposition and posterior fixation suture. We just operated the left eye. The patient had good primary gaze alignment, and that's how we left the patient. He was happy, diplopia free in straight gaze. Thank you very much for the opportunity.
What?
Here, I don't know, but it's yes available online from the CBS Online, Amazon. It's available for. Thank you for the interest.
Can we have? So we come back to another common problem of earlier known as musculofacial anomalies, but now we are grouping them as congenital cranial disinnervation disorders, the CCDDs. So, and Duane's is the leader in the CCDDs. So I have no financial disclosures. So Duane's retraction syndrome, as you all know, was first described by Hewitt, but these theory and all we can have from the books. We are not going to talk about them. The frequency is not uncommon. So we may see several of them. It's 1 to 4% of strabismus patients. Females are predominantly involved, 60%, and left side is more commonly involved. So that is an interesting thing which we need to keep in mind, and there is a very nice study which has come which explains that. 80% of the cases may be unilateral and left preponderance is there. So this is, as I said, in CCDD, a congenital cranial disinnervation disorder. What we mean is that here there is a primary disinnervation, absence of a sixth nerve or a hypoplastic sixth nerve, and there is a secondary disinnervation, that's an abnormal innervation by another nerve. Now this is the root thing in all the CCDDs, whether it is the Bell's palsy or whether it is the involving the ptosis and all. So Huber described it into type 1, 2 and 3. Type 1, as you all know, is the predominant one, in which lateral rectus doesn't act during abduction, but it acts during adduction. Type 2 is one in which the lateral rectus is acting during abduction, but also acts during adduction. So I mean, I generally like to say that it's like if you are sharing a room and there is two students, one of them doesn't study at all and doesn't let you study. That is a problem in Duane's. The other one is he studies himself but still doesn't let you study. That's a type 2. And type 3 is, of course, both of them are doing the same mischief. So when we have clinical presentations of Duane's retraction syndrome, we may have a esotropia in the primary position, and in this, what you see here, the left eye abduction is limited, and there is a narrowing of the palpebral aperture. There is an upshoot and downshoot happening on attempted adduction. So this is the classical picture of ESO DRS. What is happening in the exo DRS is that many common type 2 ones, exo in the primary position. Here the abduction is there, from here to here there is a movement. So there is some abduction, so but it is not as normal, and but the main problem here is narrowing, upshoot and downshoot. The second type of sharing room. And the congenital cranial degeneration disorders, what we meant was that in imaging you will find absence of sixth nerve compared to the controls. And there is paradoxic innervation. So this is the root cause which is causing the problem. And they may have ocular associations in the form of all this list. Important thing is the crocodile tears. If you ask the history, many of the children will say that when we eat or swallow anything, there is tearing. So when they have eating, then there is a swelling, and Marcus-Gunn jaw winking is another one. Systemic associations may be there in the form of all these cervical spina bifida, cleft palate, facial anomalies, and the syndromes, especially for the PGs particularly, you have to keep in mind the names: the golden heart, the Klippel-Field, Wilder-Wunck, Holt-Oram syndrome, Oki-Hiro, and DRRS, and IVIC, the oculo-otoradial with thrombocytopenia. So these are having these associations of systemic problems, the Klippel-Field here, and the Holt-Oram syndrome, in which there is also a cardiac anomaly which is there. Embryogenesis is, this is a landmark article from my point of view. Parsa and Robert, you should all read this article from JAMA Ophthalmology 2013. He has described what is the reason why females are predominantly involved, why left side is more commonly involved. It's the higher estrogen levels and inflammation happening, a venous thromboembolic events which is happening in the 6 to 8 week of embryogenesis. So there are causes which we can probably control. Duane's may be avoidable if we can take care of these thrombogenic influences during pregnancy: malnutrition, dehydration, alcohol, infections, trauma, ionizing radiations in the first trimester. So I mean, this is something which is different from our routine thing. Genetics is another thing. If you have, but majority of them are sporadic. So 80% of them do not have any genetic. On testing you won't get anything special, but otherwise the common genes which you may get through is the CHN1, the MAFB, the SOL4 and the HOXA1 genes. How do we manage these cases? Now this is the ESO, EXO and ortho. First of all, you have to see whether it is an ESO, EXO or ortho. Second thing is the co-contraction, very significant. Co-contraction by rule is always there. It may be mild or it may be more severe. So our management will depend upon that. Third is how much is the LR activity. Is it normal LR activity or reduced? Or, and the fourth point you have to note is force duction test positive for MR and LR or for both. Now let's take some examples. This is an ESO DRS. FDT is positive for the medial rectus here, as you can see here, and minimal co-contraction is there. So in such a situation, a single medial rectus recession of 4 millimeters, you have to be very homeopathic in doing medial rectus surgery. Lesser is better. If you do a little more, you may create a synergistic divergence excess. So you may create a iatrogenic synergistic divergence. So be careful about the MR recession dose. Be very according to the FDT. If it is tight, you have to recess it, but the minimal required for recession intraoperative FDT should be done. A little more will cause that. So if you have a significant co-contraction and you have to do more MR recession, you would have to balance it with the LR recession. And this lateral rectus Y-split recession is done. So we may do in such cases a MR recession along with an LR recession. Both are recessions. So in ESO DRS, do the minimal MR recession required as per the FDT if the MR is tight. Second is when you have to balance with the lateral rectus recession, you can do a Y-split. Mind you, the Y-split is what takes care of the upshoots and downshoots. And it is the recession which takes care of the narrowing of the palpebral aperture. Both are two different components of the surgery. If you do a Y-split without recession, you would not get an effect of narrowing of palpebral aperture being improved. Only the co-contractions will be taken care of. So both have to be done accordingly. And you may improve the abduction by doing SRT, IRT or whatever, but prior thing is first you have to neutralize the paradoxic innervation of lateral rectus. Now, unilateral recession and resection. Now, this is the anathema of what was being talked about. Resection should not be done. You have Dr. Stephen Kraft talking about the resections. Yes, in very selected cases, it may be done. But remember, even in the published articles by him, you will see that there is a problem. There is an exo which becomes more, and there is a narrowing which becomes worse. So you have to be careful, and he has also advocated never do more than 5 millimeters, and the LR resection should be about 3 to 4 millimeters, MR never more than 5 millimeters. If there is an ESO DRS in which FDT was free and there is a minimal co-contraction, then one can do just an SRT, and that will improve the abduction, correct the ESO without worsening the co-contraction, which is very minimal in such cases. So a single muscle of superior rectus transposition may suffice. So this planning of algorithm is there in an article by us in IJO. You can go back to it. This is showing you an algorithm. Now in exo DRS, what do? You have to decide on the basis of how much is the exotropia in primary position, how much is the co-contraction, which is usually very severe, and how much is the LR activity. Is it normal or is it not there at all? So some procedures we can do only if there is no normal LR activity. But if there is a normal LR activity, one should not sacrifice the lateral rectus abduction. So don't do periosteal fixations in cases in which there is some LR activity. Then we will do an LR recession with Y split. So here the exo DRS, 12 millimeter lateral rectus recession with 21 millimeter of Y split. Now these numbers you have to keep in mind. A Y split should be minimum 22 millimeters. If it is done less, as shown in many of the figures in books, it will not work. So you have to do good amount of that, because that is what is correcting the upshoots and downshoots. And the recession, as I said, will depend on the FDT of the lateral rectus and the exo deviation in the primary position. So you would have to do as much as required. So in this case, we did LR recession of 12 mm with 21 millimeter Y split, and here you can see the correction is there. So this is what you can get. Do we need to see this video, or we can skip this? So in just reverse of medial rectus, lateral rectus recession, little is no good. Here you have to be non-homeopathic. You have to be very proactive and do as much required, because the lateral rectus is the culprit. It is the problem. Never leave the terrorist with little bit of kicking. You have to take care of it, and that's why we do periosteal fixations in cases of very severe co-contractions in which the LR activity is not there. So he is not of any use. What do? We put him in the prison forever. So that is the compartmentalization of lateral rectus, periosteal fixation, and to improve the abduction, we can do the partial VRT or any other procedure. So the periosteal fixations of the lateral rectus, just see this, what is done. So you will choose only those cases in which LR activity is not there at all. Then you will do the periosteal fixation of lateral rectus. So here the LR is very tight, it's being hooked. So this is loose. I think loose है कुछ. यहीं से हिला शायद. So in exo DRS, when we are doing, we have to be taking care of the normal LR activity. If there is an LR activity, choose to do an LR recession with Y split. If there is no LR activity, then we will do a periosteal fixation. So, and if there is an ortho DRS, which is the most complicated type of DRS, many a times we would like to leave them to the opponent, to the other people, send it back to another person who will face the music. But if you have to be the person who has to finally take the call, what will you do? Then you can do a adjustable MR recession to control the ESO effect and the LR recession with Y split. So that will be the take on the DRS types. So mostly we have, and to improve the abduction, we have a choice of doing क्या हो गया? बंद क्यों हो गया? Okay, so I think we will move on to Dr. Ramesh to talk about congenital fibrosis extraocular muscles till the time we have that. So we'll come back to this. As you all know, Dr. Ramesh is from LVPI, and I think we don't have to tell, he's such a known figure now, and a wonderful person, and also a very good orator and speaker. And that's why I have given him the most complex problem of strabismus, the congenital fibrosis of extraocular muscles. And he's going to do the handling of these complicated cases and make it easy for you. He's also not there, but his video is there. Ah, he's gone.
Somehow there is a problem. No, ये तो प्रिंट है. मैं इसको पेन ड्राइव में दे दूँ? ठीक है. In between you can take some questions, sir. इसमें ले लो पेन ड्राइव.
If there are any questions in the meantime.
उसमें आ रहा है क्या? They are putting it here.
नहीं, मैं इसको अलग से फिर आपको कनेक्ट करना पड़ेगा. इसमें कर लो. डायरेक्टली से कर लो, फिर एक ही रहेगा. उसके बाद आपको Yes?
Yeah. Mic, de do please.
Correct.
Is it routinely done in palsy cases, or you just suspected that this patient could have a visual field defect and you went ahead with it?
Yes, it should always be done. Even if for all cases of paralytic strabismus, always do a confrontation field in your clinic itself. And whenever you have a suspicion, do a Humphrey visual fields. You may do just a simple 30-2 if that is the one which is commonly available. But it should be done. It will tell you many things.
And what about children with CVI and who have squint? Because that's very important as they have visual field defects, and then you need to decide whether you need to operate on the squint or not.
CVI cases, actually, you have to do an imaging in most of these cases. And I think a very nice article has been published in IGO, and along with a commentary by one of our colleagues, Dr. Swati Fuljile. You can go through the cases of that, and the classification on the basis of imaging can be done in these CVI cases.
Squint surgeries invariably you would want to do based on the presence of squint. rarely would you change. Usually, often these patients have inferior field defects and not ones which would really matter for their strabismus point of view. And it's
To have
important.
nasal field defects and they have exotropia and you correct it and then you make it worse for them.
So it's uncommon that they would have very clear characteristic field effects of hemifield, but as sir is saying, invariably we will get an imaging done in them. It's more often than not that we will be having an imaging. So if you suspect that, that's different, but usually they have very diffuse involvements of the visual pathway. They're not so discrete that they have one-sided involvement only, so you're not going to have a hemianopic field effects. That's very, very unlikely. So it's usually the ones which sir showed, the hemianopias or the bitemporal hemianopias, ones which are post-trauma or infarct. So it's rare that congenital anomaly or problem is going to be such localized. Usually they always do better after aligning the eyes.
Okay, any other questions? Oh, it's there. Fine. अच्छा तब तक उसको जरा देख लो.
Thank you very much, sir, for this opportunity. It's always a pleasure to present in front of I must say that living legend, Dr. Sharma. Two things happened. It's always a pleasure to meet every one of you in person. So that's one change happened this meeting. And the second thing is that we don't have to accommodate so much to listen to a talk. You can relax your accommodation. So management of congenital fibrosis syndrome, it's as you know, it's one of the CCDDs of many of them. What happens is it's a CCDD, you know that it's miswiring at the brain level. So whatever you do, there'll be suboptimal correction. This is what we must understand. And the second thing is it's pretty rare. But even if it is rare, there are at least 10 or 12 cases will come in a year to a private practitioners. Probably in an institute it will be close to 40 or 50. This is what is the reality of this fibrosis syndrome. The culprit is here. KIF21A is the most important for the type 1, and the tubulin gene. These are the neurotropic genes which are defective here. Routinely, this is the classification which affects either oculomotor nerve or the nucleus of that, or trochlear nucleus and nerve, and its innervated muscles. So that's the whole pathology of this CFUM. If you look at the classification, there are significant clinical phenotypes. It's not like one set of syndromes you see. There is the genetic classification is more informative. Otherwise, your classical textbook type 1, type 2, type 3 is not always true. So you have many, many varieties as close to 8 genetically defined syndromes. But the most common ones are these 3. This is important to really clinically, phenotyping in terms of type 1 is prominent, usually bilateral ptosis, which is symmetrical. Type 2 also, it's bilateral ptosis, may or may not be symmetrical. Type 3 is usually unilateral, not always. And the second thing you must remember is type 1 is usually hypotropic eye. It's not that always it's true. They can have a little bit component of exotropia as well. And the type 2 is usually exotropic. And some of the retinal dysfunction, pupillary abnormalities are seen in type 2. So meiotic pupil, if you see with CFUOM, mostly it is type 2. Mostly, it's not 100%, but mostly clinically you're right. And if you see any kind of neurological symptoms, findings, it's type 3. Type 1 is autosomal dominant, 2 is recessive, third can be autosomal dominant usually, but there could be germline mosaicism. It can mimic autosomal recessive. Why it is important? Because these are the three genes which are the culprits in these syndromes. And obviously, always have the pedigree chart ready. This is one of the typical autosomal dominant type 1 with the KIF21 mutation. And these are the clinical manifestations. You can see a large hypotropia. That's why I said it's not always just hypotropic. They can also have exotropia. Type 2 is usually very large exotropia with adduction limitation in both eyes, and normal abduction. They will have retinal dysfunction. Sometimes ERG is very important, and also looking at the finding of pupil is important. This is a typical type 2 CFUM. Type 3, this is generally unilateral. They can have associated horizontal deviation. It can mimic like MED. It is possible with horizontal deviation. So you must differentiate. Sometimes it may be, genetic test may be required to really prove it or disprove it. And always observation is very important. Dr. Sharma showed that observation is very, very important. You might see some of the association. In this, what is common is the extraocular motility problem, and there is a novel mutation in chromosome 21q where they have absence of ulnar bone and also the finger abnormality. So they will have something common in these kind of situations. This is common in Duane syndrome also. You saw it's not so common, but unless you search for this, you may miss these problems. I would like to just present 3 or 4 cases and then stop there, so that you will get an overview of the surgical management of these cases. Again, the goal of surgery is not really making them in ortho in all positions, making their life better, making their quality of life better. And you saw in the first title slide where the child was using the finger to open the eyes. It's a blinding disorder for many children. So that's what we are looking at. So look at this guy who has a very large abnormal head posture, hypotropia in primary position. He is not able to elevate. Krimsky's test is what we really use. Sometimes even that is difficult. Cover test, it's not possible in all the cases. You can see the abduction is good in the right eye, but there is significant adduction limitation in both eyes, and also elevation deficit. So obviously it's not that imaging is a must, but I just want you to show here. Normal study, you can see the muscles there, but in this patient you can see hypoplastic. It's not a myopathy, it is still a neuropathy because there is no nerve supply. The chromosomes of that is affected. That's why muscle underdeveloped. You can see what is normal in this patient is the superior oblique. Look at the size of superior oblique. That's why they will have a very, very large hypotropia in the primary position, because superior oblique. Sometimes you might have to do a superior oblique tenotomy also in these cases, in severe cases. So that's a comparison of normal and abnormal MRI, quasi-coronal cuts. The challenges are they do not follow any laws like a backbenchers. They have a significant pulley and insertion abnormalities. No rules for surgical dosage. Whatever tightness, you have to release it. But on table, if you can aim for overcorrection, that is the mantra for CFUM. If they have a exotropia, if you can get a large esotropia at the end of the surgery, obviously it will be under GA. That is the good target, I must say, in most of the patients. Or even on the first post-op day, whoever has overcorrection, they have a long-term good outcome. You can also use stage procedure. Most of them are lost their binocularity. So sometimes you may have some of the pearls I would like to share here. While exploring SO, you will see that SO tendon insertion is abnormal. That's one of the things you can have. Tight superior oblique. And you can also have anterization of superior oblique. And also you can have KIF21. The type 1 may require a very, very large weakening. This is one of the paper by or one of our friend, Kumur Sener. You must, all of you must read his paper. It's there on the strabismus surgery in CFUMS. What he says is, what's most important is do a large recession, but have a counter traction. If you don't have it, over a period of time, they will come back. So you have to have that stay suture kind of things for some days. I personally don't use it, but he suggests in many of the cases it's important. And always look for fibrotic bands. This is for all the types of CCDDs. And what we did in this particular case is a very large lateral rectus recession and medial rectus resection. Left eye we did periosteal fixation because he was fixing with only one eye. We wanted to get it adducted so that he can correct his abnormal head posture, and also superior oblique nasal transposition. A lot of surgery has been done at the same time for this patient. So this is the 1 month post-op picture, and as I said, you can't make it perfect, but he is happy with this outcome, and still he is exotropic in that position. This is one more girl. You can see a large esotropia with hypertropia there. Amounts to, it looks like, immediately it looks like a type 3, but if you see the right eye, there is a problem there as well. So we haven't done the genetic test in this case because she had not any inclination for that. So, but we don't know, but you can see this hypoplastic muscles on both sides. Especially the superior rectus you see on the left side, and also oculomotor nerve abnormality. And we did the inferior rectus and the medial rectus. It was super tight. We relaxed that, and then you can see she's not bad again. She's happy with the outcome, but still she has a little bit of abnormal head posture, and she's doing well. This is again one more large esotropia. With that we did the surgery, and you can see when you correct the esotropia, even the ptosis became better. He did not have additional ptosis surgery here. And that's the last case I'm going to show. Very large exotropia. We had to do a very supramaximal resect for this patient, and you can see still it's not perfect, but we could get this is what I just wanted to show. On the table or on the first post-op day, look at the middle picture. It looks, she looks much better, but see what happens after 2 months. It still diverges. So these muscles, in spite of having overcorrections, sometimes over a period of time they can have. This is the pre-op head posture. This is the post-op head posture. So to conclude, I would say careful force reduction test is very important, and then you can do a large recession. Best results are expected in patients with CFUM type 1 who can expect a marked improvement in head position and acceptable ocular alignment in primary gaze after recession of inferior rectus and ptosis. Due to the rarity of this disease, surgical treatment can pose a great challenge. It's not that two cases are similar. Each case is different. Investigating for associated abnormalities are important. If possible, one must do the genetic counseling, because this is important, because many times they can come with the thing. It's only to improve the quality of life, not a perfect alignment in these cases. Thank you very much. I just would like to invite you all for the 4th grand rounds in pediatric ophthalmology and strabismus in Kolkata in August, and also WSPS meeting in Milan. If you all would like to go abroad, you're all welcome, and the deadline for abstract is June 7th. Thank you very much.
Thank you, Ramesh. I think it was very interesting to talk, because CFUM, as you know, is difficult, and always remember a perverted convergence, which is another problem. So whenever you deal with the horizontal position, you may still have a problem of this one. So I think we may have this nice presentation by Dr. Murli now on blowout fractures and flap tears.
Good morning, everyone. I sincerely thank my mentor, Professor.
Yeah.
Sir, you mentioned
Yeah, what I do is I don't do much of that traction, but Kumar Stener always does because the muscle will be in that position for a lot of time. What I try to do is a small injection of botulinum toxin.
In
I
the
give
same
it to the
muscle.
other muscle, so that it remains in that position. That's what I do. But my favorite approach for it is a very large recess resect and make the tightness free wherever the muscle lies. That's where it's similar to thyroid. That's what I would do.
So with what did he do the counter traction?
Sutures. He takes sutures
Like
Non-absorbed.
through the non-absorbable
So,
suture
sir,
and then
just
remove
leave it there.
Yes.
After how many days?
A week or so, or 3-4 days.
And so most of the patients would have also had the head posture because of the ptosis, right? Because all of them had ptosis and brow elevation. All the
Correct.
pictures had.
Contribution by the ptosis is very limited compared to abnormal globe positions.
So did you offer the ptosis surgery to the patients who
Yes,
had
we
chin
do.
elevation?
We do offer in some of the patients. These patients, whatever I showed, I did not do
Okay.
because the hypertrophy was there when you released it. They had a good outcome. But there are some patients we have to do a sling procedure, very limited sling. It's not that we can do a large one because they will have exposure.
Bell's is poor. Huh? So how's the prognosis of the ptosis surgery?
Not so good. You can expect a correction of 50 to 60%.
So remember, CFUM is third nerve palsy embryogenically.
Yeah.
So it is going to be having the same problem of ptosis correction.
Yeah. Again, it's a decision on the table. When the muscle is so tight, even if you put, if one does not want to do a periosteal fixation, Dr. Sharma showed 2 cases where he did a LR recession of 24 millimeter.
Yeah.
That also would do in these patients. Because even in third nerve palsy and also CFUM, even after detaching the muscle, if you do an FDT, there are orbital factors also contributing to this. It's not just muscles. So if you want to really detach the complete force of LR, that's one of the most weakening procedure for lateral rectus weakening.
It
Thank
also
you, Ramesh.
prevents
So
the
now we
recurrence
move on to
of
the very
reconstruction.
interesting topic of blowout fractures and flap tears. Again, Dr. Murli is not here, but his recorded talk is here. So we will have that.
Dr. Pradeep Sharma sir for having invited me for this wonderful meeting. I'll be talking on blowout fractures and flap tears.
Volume बढ़ा दो.
So as we all know, pediatric orbital trauma is a diverse clinical condition with an age-specific clinical presentation. So there are many challenges in the management of pediatric blowout fracture. The treatment of adult blowout fractures is fairly standardized, but in children there is paucity of literature and less consensus as to the management. Children are not young adults. The differences is because of difference in extent of facial growth and development, the extent of paranasal sinus pneumatization, dentition, and the structure of bone and soft tissues is not the same as in adults. In children, the skull to face ratio is 8:1. Note the frontal prominence in children. So the incidence of orbital roof fracture and forehead fractures is more common than blowout fractures in children. In adult, this disparity becomes 2.5:1. In addition, many of the sinuses which act as shock absorber protecting the brain and eye from injury are not pneumatized in children. So you would not get a blowout fracture of the orbital floor in children as young as 8 years of age because the maxillary sinus is not pneumatized. So blowout fractures in children are typically a trapdoor fracture. That is, the displaced fragment would spring back to its original position, trapping prolapsed orbital tissue. So in adult orbital fracture, you can have a number of orbital signs like periorbital edema and ecchymosis. In children, you get typically a white-eyed blowout fracture. In children, in addition, you can have nausea, vomiting, bradycardia because of oculocardiac reflex, in addition to limitation induction. This article by Burr et al. Is very comprehensive and deals extensively with orbital fracture in children. In this series, the etiology of orbital blowout fracture was mainly a road traffic accident or a fall and or injury during sports. And floor fracture was the most common fracture in this case series, affecting 33 out of 37 children. So this patient sustained injury by bumping on a flower pot. his mother noticed this face turn and got him over for a routine eye exam. Note that the only sign in this child, it was a 1-day-old injury, the only sign in this child is a right eye depression restriction and abduction. So there you go. This is a right eye depression restriction and abduction. We got a CT scan done of the orbit, and it shows a teardrop sign with entrapment of the inferior rectus. Note that there is no bony displacement. Patient presented fairly early. The surgery was also done fairly early. So we managed to restore anatomical continuity of the inferior rectus and achieved resolution of the face turn. So this patient had a fall from the staircase 1 day back. Note that the only sign in this child, there's hardly any orbital swelling. The only sign in this child is a right eye depression restriction. So it's that difficult to get this clinical sign, but you need to carefully watch. See, note the right eye depression restriction. So this patient also had a similar clinical picture on CT scan. The surgery should be done as early as possible within 7 days for the best outcome, because late surgical correction is associated with ischemic injury to the prolapsed orbital muscles, resulting in persistent diplopia. For non-entrapped orbital fractures, the surgical indications are same as in adults. The presence of a significant enophthalmos globe, malposition of fracture size, more than 50% of the wall size would be an indication for surgery. In adults, you may wait for a couple of weeks for the edema to settle down, but in children, it is as early as possible. We prefer using a Prolene mesh for this. So for orbital roof fracture, the most common indication for surgery would be a bony fragment that would impinge on the superior rectus, causing motility restriction. Thank Dr. Vidya, our plastic surgeon, for sharing these slides with me. So note the left eye elevation restriction in this child, and note the orbital roof fracture with the bony fragment impinging on the left superior rectus muscle. Can also present with a pulsating proptosis because of transmission of CSF pressure to the orbit. So this could result in a growing orbital fracture because of continued transmission of pressure. So you need to be conservative, minimal manipulation to prevent growth disturbance. Note that some of these implants can get dislodged later because of orbital bone growth. So minimal manipulation, minimally invasive surgery. So I would now come to muscle tears, flap tears in particular. So Ludwig and Brown published their landmark article in which they noted 3 anatomical variants. One is that a segment of muscle and tendon could be missing. The orbital layer of the muscle could be missing. The muscle that is torn, part of the muscle that is torn. A flap tear is simply a partial muscle tear. The muscle that is torn could be encased in adherent orbital fat. It could be associated with orbital fracture. Anterior attachment of the flap acts as a tether, and posterior flap position causes pseudo entrapment. So the motility restriction could either be in the direction of muscle or opposite to it. So this patient, the history is all important in diagnosis. This patient was traveling in a bullock cart, sustained injury with a hook, and developed this strabismus. So I would show the surgical video, not typically a flap tear, but again, note the pseudotendon at the insertion. We tried exploring the LR all the way behind the inferior oblique insertion, could not retrieve the muscle. So did a transposition procedure, transposed the inferior rectus, which was hooked and split into half. The superior rectus was subsequently hooked and cleaned, freed from the superior oblique attachment. We did a Hamilton's procedure in this patient, and satisfactory alignment was restored in primary. Satisfactory alignment was restored in primary position. So this patient sustained a Bulgor injury. So CT scan showed a partial injury to the muscle way behind the equator, and we had to do a transposition procedure because exploration this far back, and the patient also presented many days after injury was not possible. Typically, the inferior or the medial rectus is involved in injuries because of Bell's phenomenon, when the patient squeezes his or her lid to protect himself from injury. So this patient also had a Bulgor injury. This was also a partial tear, and the injured fragment is prolapsing out. What happened in this patient was that the proximal fragment of the muscle was encased in orbital tissue. There was orbital fat collapse also. So we managed to retrieve and attach the muscle flap back to the insertion. So this is the alignment. The hypertrophy is fully corrected now. And the areas of fat collapse, we managed to either repair or close it with a Tenon's patch graft. This is very important because...
So I think this is almost the time that we have, and what Murli was showing was the inferior rectus flap tears have to be managed a little differently. They may have two flaps, the orbital and the global segment, and this orbital one sometimes may have a reverse leash effect. So if you just sacrifice it, it may work. So that is what is the lesson to be taken from the flap tears that is done. But these are very interesting cases which we have to deal with differently. I think we are short of time for that, but we will love to have your questions maybe whenever outside or when it's possible. So because Dr. Jagatram is already here and his session has to start. So thank you all for a very nice audience, and we would love to have your questions even now or otherwise on the other groups when possible. Thanks once again.